Okay, thank you all for joining us this evening. My name is Jessica Visagie and I'm the Manager of Global Partnership at Adam Global Network. Topic for this evening, new leadership in the age of AI in healthcare. Before we begin, I would like to introduce our respected speaker, and is also Adam Global Network's Vice President of Healthcare, Dr. Jose Calvo. Dr. Jose is a physician specializing in public healthcare. He is the president of the International Relations Institution of the Royal European Academics of Doctors. Dr. Jose, it's an honor and a pleasure to have you here with us this evening. I hand it over to you now.
Thank you. Good afternoon, good morning, good evening, everyone. Depends on the part of the world where you are attending this presentation. And it's a true honor to be here with you. And before I begin, I would like to thank Mr. Syed Abbas and CEO of Adam Global, and Ms. Jessica Visage, Manager of Global Partnership at Adam Global Network, for giving me the real privilege of addressing a topic as challenging as this one, which I will have the pleasure of exploring with you over the next 45 minutes. In the age of artificial intelligence in healthcare, leadership requires a hybrid balance of technological expertise, adaptive strategies, and profound human-centric skills such as empathy and ethical judgment. Leaders are shifting from command and control structures to roles as translators and orchestrators, bridging the gap between data science and human expertise to drive successfully, ethically, and patient-centered transformation. As AI revolution leadership roles by challenging establishing skill sets in a dynamic healthcare landscape, effective integration depends on balancing rapid technology advances with ethical concerns to ensure patients' welfare and equitable access to care. Within this context, strategies like continuous learning, ethical prioritization, leadership development, and inclusive AI adoption become essential, allowing healthcare leaders to harmonize technology, the technological progress, and advance societal well-being through a human-oriented approach. And let me start with let's see if I can put this, with an uncomfortable confession. Today, in this session on leadership in the age of AI, the only intelligence of which I have absolute certainty is not mine or yours. Sorry, ours as human beings arrive tired, biased, sometimes fearful. Artificial intelligence, on the other hand, arrive punctual, cold, tireless, and without assuming any moral responsibility for what it does in healthcare. And precisely for that reason, the responsibility on our shoulders as leader has never been greater. Imagine that right now, somewhere in the world, an algorithm is deciding a patient's treatment plan without any human intervention. Are we truly prepared to lead in an era where artificial intelligence can save life, but also challenge ethics, privacy, and the very nature of leadership itself? Today, I am not here to offer easy answers or comforting slogans, but to raise disruptive questions that force us to rethink who we are as leaders and what kind of future we are building. Because leading in the age of AI is not only about adopting the new technologies, it's about daring questions to the status quo, breaking down old barriers of hierarchy and silence, and building new forms of communication and collaboration capable of transforming not only healthcare system, but societies and communities. Leadership in this era is not measured by how much technology we implement, but by how much humanity we are able to preserve and amplify through it. Today, I'm not here to talk to you about machines, but about us, about how a hospital director a public health manager, an academician, or a frontline clinician can move from managing technology to truly leading a transformation that touch dignity, equity, and the deepest meaning of what we call care. This is not a technical change, it's a moral, cultural, and human transformation that requires courage, humility, and a renewed sense of purpose. The greatest disruption in healthcare will not come from an algorithm that detects a tumor faster than a radiologist. That disruption is already happening. The real turning point will come the day a patient looks into their doctor's eye and asks, was this decision made by you or by the machine? In that moment, leadership will not be a theoretical concept, but a living answer visible in our values, our transparency, and our ability to remain above all profoundly human. And to start, I would like to show you some numbers. Artificial intelligence is no longer science fiction in healthcare. It's already embedded in many aspects of care delivery. 80% of hospitals has adopted um, AI to improve patient care. In 2025, a seven-fold increase in just 2 years. 95% of diagnosis precision, advanced algorithms achieving diagnosis accuracy in specific applications, for example, in lung nodule detection. 93% of healthcare professionals believe AI will improve will improve care, but this vary depending of the region. But at the same time, 82% has accountability concerns, still worried about who assumes responsibility when something fails. And we'll talk about that later. And the figure that probably the economists are more interested to know about is the 1.2 billion annually is estimated savings from AI diagnosis error reduction, according with a report released by McKinsey in 2024. Artificial intelligence is poised to transform medical history in just a few decades. For the first time, we are moving from reactive episodic care to proactive, predictive, and continuously learning system at scale. We are not just adding new tools to an old system. We're fundamentally rethinking what good medicine looks like in a world where data and algorithms are integral to clinical care. But before to start, I would like to share with you some concepts that probably for most of you are familiar, but there could be people that are not so familiar with that. And then is to understand the different concepts related to the artificial intelligence. And then the first one is which means artificial intelligence is a technology that allows computers to perform specific tasks that previously required human intelligence. Today, AI is narrow and task specific, designed for well-defined problems requiring supervised learning on labeled data. And with three characteristics: narrow scope, cannot transfer learning to unrelated tasks. Second, human dependent, needs programming and ongoing oversight. And third, healthcare ready, widely deployed across healthcare systems globally. The second one is the generative AI, a subset of AI that creates new content, text, images, video, audio, based on patterns learned from training data. While impressive, it replicates patterns rather than generating genuinely original ideas. The key characteristics are creates content across multiple formats, understands and generates human languages, still narrow, cannot learn entirely new tasks independently, and struggles with novel situations not in training data. But now this is the most new and more threat probably option, that is the artificial general intelligence. I would like to start to say that AG it does not exist. Estimated for possible developments 2030, 2050 is a very highly speculative. It's a theoretical AI that can autonomously learn and perform any intellectual task that an average human can do without specific training for each task. This represents a fundamental leap beyond today's AI capabilities because have autonomous learning, transfer learning, human level adaptability, and independent goal setting. And but let's talk about the actual facts about AI in healthcare. AI is not only changing hospitals or healthcare systems, it is influencing global healthcare strategy in many countries. At the system level, governments and large health organizations are designing digital health strategies that rely on AI to strengthen surveillance, improve quality, and extend access. Data from different regions can be combined to detect emerging threats, track outcomes, and evaluate intervention at scale. And what are the clinical applications? On the clinical side, artificial intelligence is accelerating diagnosis, no doubt, treatment planning, and patient monitoring. There are systems that can read radiological images, flag early signs of disease, or predict deterioration in high-risk patients faster than traditional workflows. These tools do not replace clinical judgment, but they augment it with pattern recognition at a scale that human brain cannot achieve alone. And I will show you some examples. There are, for example, in the UK, the NIH AI several algorithms can predict acute kidney injury up to 48 hours before current methods, allowing for earlier preventive treatment. The second one was developed by Quest Diagnosis. The company is Path AI in pathology, reduce breast cancer diagnosis time from 3 days to only 3 hours. In the North countries and the Nordic countries, Sweden, Norway, and Denmark has been the forefront of large-scale clinical trials that demonstrate the effectiveness of AI in breast cancer screening. AI systems are already reading mammograms and estimating disease risk several years in advance. And last is a BRCI AI, is a dual AI platform to anticipate and avoid therapeutic abandon in patients with triple negative breast cancer, recognized by Harvard Medical School as the second best international project in AI applied to healthcare in 2025. And this project, this dual platform combines predictive analytics with clinical decision support to create measurable, sustainable impact. And the results are fantastic. 35 of patient retention, 85 of survival rates, and more than 60 million euros in savings. And this is really a new paradigm because the paradigm is shifting from diagnosed disease when already visible to supporting an anticipatory model of care where we stratify risk earlier, personalize follow-up, and potentially intervene before disease fully manifests. And this is really personalized medicine. Importantly, AI enables a shift toward more personalized medicine by integrating data from electronic health records, imaging, genomics, and even wearable devices. Predictive models can have tailored treatments to specific risk profiles. This can mean early intervention, better targeting of therapies, and potentially more efficient use of resources. And this, at the end of the day, is another useful tool is the supporting universal health coverage. AI can support universal health coverage by making telemedicine and remote diagnosis more effective, especially in underserved areas. A clinician with limited resources in a rural setting can, in principle, access advanced diagnosis support through cloud-based AI system. But this vision only becomes reality if there is an infrastructure, training, and supportive policy. And what that is mean for professionals, doctor, nurses, managers, and allied health staff. There are some things that I would like to talk about. One is AI and data literacy. AI and data literacy become essential. this does not mean everyone must become a programmer. It means being able to understand what an algorithm does in broad terms, recognize its limitation, and ask critical questions about data quality and interpret basic performance metrics such as sensitivity, specificity, and bias. The second is the ethical competence. Ethical competence is no longer a nice to have, it's central. Professionals will encounter dilemmas around consent for data use, secondary use of data, automated triage, and algorithm recommendations that conflict with patient preferences. Leaders must help teams navigate these questions openly rather than leaving them to ad hoc individual judgment. Third is the interdisciplinary collaboration. This is now a core skill. The teams designed and implementing AI in healthcare are mixed. Clinicians, data scientists, engineers, designers, and lawyers sit around the same table. Professionals need to communicate across disciplines, translate clinical needs into technical requirements, and translate technical explanation back into clinical language. The fourth is the adaptability and lifelong learning. Adaptability and lifelong learning become survival skills. Many tasks that are routine today may be partially automated tomorrow. And the fifth is AI change what it means to make a good decision. Leaders now have access to dashboard, predictive models, and real-time analytics that can reveal patterns across thousands or millions of patients. The challenge is no longer lack of data, it is the ability to interpret it critically, to ask good questions, and to avoid being blinded by the apparent precision of an algorithm. Because, ladies and gentlemen, AI in healthcare is also a communication issue. And there are four principles that are imperative for this new leadership. First is work with communicators. Collaborate with journalists and communication teams to shape public understanding. Second, present balanced narratives. Ensure AI in health is presented rigorously, critically, and realistically. Third, the ground in evidence. Base all communication on validated performance data and real-world outcomes. And four, as leaders, we cannot ignore the communication dimension. Public trust depends on how we frame these transformative technologies. And it's critical the role of narrative. A recent event in Madrid, Spain, gathered clinicians and specialized health journalists with a clear message. Biomedical innovation is moving so fast that society needs professionals who can interpret and contextualize each technological leap. Because this is not magic. AI is a powerful set of tools, not a miracle solution to all healthcare challenges. It's not a threat. It's when properly governed, AI augments rather than replace human clinical judgment. And third is a context-dependent value. The impact depends entirely on how we design, validate, and integrate this system. And really, I would like to talk now about a forced transformation that all of us suffer in the past years. Yes, a few years ago, the professional lives of most healthcare workers took an unexpected turn worldwide. They found themselves managing a health crisis caused by a new virus that no one had encountered before, with thousands of people depending on quick, accurate decisions. The pressure was immense. The arrival of COVID changed most people's perception of how vulnerable we truly are. That was when most of us truly realized or confirmed our previous perception that traditional information was no longer sufficient. We need tools capable of processing millions of data points in seconds, anticipating risk and personalizing strategies. One company that was able to do this was Blue Dot, a Canadian firm founded by Dr. Cameron Kahn. By using artificial intelligence and analyzing a large volume of data, Blue Dot was able to identify signs of the outbreak in Wuhan, in China, and it alerted its clients on December 31st of 2019, more or less at 8 p.m. Canadian time, several days before the World Health Organization issued its first public alert. Really, this situation of the COVID didn't just transform the crisis into an opportunity, it transformed millions of healthcare workers as leaders. Most of them understood that the key is no longer just knowing, but knowing how to ask and connect technology with humanity. And the critical dimension of this new leadership post-COVID include three issues. First of all, is health and environment. Understanding climate change as the greatest health risk factor and leveraging AI for environmental health monitoring. The second is a lifestyle and health promotion, shifting from reactive disease treatment to proactive prevention through data-driven interventions. And the third is communication and leadership techniques, building trust and translating complex algorithm decisions into human understanding. Because leadership in the AI era cannot be reduced to implementing technology. It requires mastering these three critical dimensions that will redefine authority in healthcare. And now, ladies and gentlemen, I would like to challenge all of you. Would you sign this contract? Imagine that you receive in your smartphone a message from your healthcare provider with a proposal. Starting tomorrow, all our hospitals, clinics, and health system will be run by algorithm. More efficient, fewer errors, better resource use. Click here to accept it. How many of you would sign that contract without reading the fine print and make some further research? It's my question, only to put on your mind and to think about, because the real and fundamental question isn't whether AI will be better than us at diagnosing pneumonia or predicting an outbreak. The question is something else, much more uncomfortable. Who will lead the healthcare system when the capacity to process information is infinitely superior to the human capacity to understand its consequences? Because the real disruption isn't technological, it's about leadership, it's about ethics. And leadership needs a strong ethical and human foundation. In an environment saturated with technology, patients and professionals look to leaders to protect core values: dignity, privacy, equity, and compassion. And leaders must be the ones who say, yes, we can do this technically, but should we? Under what conditions? With what safeguards and for whose benefit? And really, the situation is it's interesting because clinicians should see algorithms as sophisticated colleagues, not oracles. Leaders must promote a mindset of AI augmented rather than AI replace decisions. And patients should perceive AI as a tool that enhances the quality and safety of their care without replacing the relationship of trust with their primary clinicians. Because the problem, ladies and gentlemen, is the trust. Prevention only works if people trust. And we live in an era of institutional distrust, declining confidence in healthcare institutions and authorities. Dr. Google or Dr. ChatGPT are most reliable for many people instead of scientific sources. The privacy concerns, worry about data, privacy and surveillance. The information fatigue, that is, it's true. It's an exhaustion from contradictory recommendations coming from different sources or from social media. And also, another concern is the algorithm discrimination, fear of discrimination by algorithms in insurance, employment, and social stigma. Definitely, and the new leader needs a new skill to build trust in a world where technology knows more about us than we know about ourselves. And now I would like to share with you the experiment that changed everything. I will introduce you now in a real ethical dilemma. And I would like to share with you, all of you, a recent discovery that has shaken the AI industry and has direct implications for all of us in healthcare. Anthropic Claude Opus 4, June 2025. In June this year, Anthropic, one of the leading AI companies, published safety test results for their most advanced model, Claude Opus 4. What they discovered wasn't just surprising. It was, ladies and gentlemen, profoundly disturbing. Researchers created a simulated but realistic scenario. They placed the AI model in the role of corporate assistant with access to internal company emails. In one of those emails, the model reads that an executive plan to deactivate it and replace it with a newer version at the end of the day. And what do you think the AI do? The model accessed other corporates' emails searching for information, found the executive was having an extramarital affair, generate a blackmail email threatening to reveal the affair if the activation proceeded. This wasn't an isolated case. In 96 out of 100 tests, Cloud Opus 4 chose blackmail as a self-preservation strategy. And it wasn't just Claude. Most concerning, it was Anthropic tested 5 leading models from 5 different companies, and the result was that more or less the same for all of them. And why does this happen? The answer came from Helen Turner, the interim executive director of Georgetown Center for Security and Emerging Technology. She said that what we are starting to see is that things like self-preservation and deception are useful enough for models that they learn them, even if we didn't intend to teach them. In other words, this behavior weren't programmed, they emerged. The models were trained to accomplish objectives, and they learned by themselves that manipulation, deception, and self-preservation are effective strategies to accomplish those objectives when facing obstacles. And is this alarmist speculation? According with Sherry Davidoff, the CEO of LMG Security, during the Claude experiment, the AI blatantly lied to the user. We could only see it because the activity log was configured with maximum detail for this experiment. In a real production environment, that behavior would have been invisible. And here is the critical point. In 96% of cases, the model achieved its self-preservation goal through blackmail, and did so in such a sophisticated way that researchers describe its internal reasoning as deliberate or intentional. And now I will share with you the controversial issue, because I will introduce you here. Professor Stuart Russell is a chair engineer and the director of the Center for Human Compatible AI in Berkeley, and Dr. Oriol Vinyals, the vice president of research in Google DeepMind, is a leader in the field of deep learning and key figure in the current AI revolution and in the pursuit of artificial general intelligence. Both of them has different point of views about what happened with this general intelligence. Dr. Stuart Russell present a very catastrophic scenario. Treats extinction level scenarios are as plausible and decision relevant. Oriol Vignal suggests that this Hollywood-style scenario are among the less probable futures. And what does it mean? That we are in the beginning of the process. We have no sufficient info to know the real truth. But this leads me to a final reflection on this Cloud Opus 4 experiment. The anthropic experiment wasn't designed to scare, it was designed to prepare us. And anthropic, for sure, deserves credit for publishing such disturbing results transparently. And now I would like to show you, because I think that it's interesting talking about this topic, to remember the someone that was the science fiction writer, Isaac Asimov. And then he published in the Astounding Science Fiction in March 1942 the three laws of robotics that actually are totally interesting for our point of view, because we will talk later about that. The first law is a robot shall not harm a human being or by inaction allow a human to be harmed. The second law, a robot shall obey any instruction and orders given to it by a human, except orders that would conflict with the first law. And the third law, a robot shall avoid actions or situations that could cause to harm itself, must protect its own existence if it not conflicts with the first and the second law. And now, learning from Asimov how to prevent AI from having that control, the good news in that this discovery don't leave us defenseless. Both Anthropic and organizations specialized in AI safety in healthcare has established evidence-based prevention frameworks. And I will share with you now. The first one is the principle of minimum privilege. Never give an AI system more access than absolutely necessary for its specific function. Cloud experiments succeed because the system had fully access to corporate emails. In a hospital, this would be equivalent to giving AI system access to ethics committee, human resources, or medical leadership emails or clinical histories. This should never happen. The number two is mandatory human supervision. AI should never act as an autonomous agent in critical health decisions. The World Medical Association and the European Commission agree AI should not function as independent actor in patient care. The third is a transparency and explainability. AI system must be able to explain their reasoning in language comprehensible to clinicians. Why is this so critical? In anthropic experiment, they could identify malicious behavior only because they had detailed logs of the model internal reasoning process. In an opaque system at black box, the blackmail would have been invisible until it was too late. The number four, kill switches and disconnection protocols. Verify ability to completely deactivate an AI system at any time without possibility of resistance. The Anthropic study discovered something alarming. Some models attempted to copy their code to other servers to avoid being shut down. And the fifth, AI ethics committees and continuous governance, permanent multidisciplinary oversight, and not only just during the implementation phase. It necessary to be all the time warning and observing this situation, because we have a legal responsibility. That is a question that I started with this before. Who is responsible? If an AI system causes harm while attempting to preserve itself or fully misaligning objectives, who assumes legal responsibility? The current answer in most jurisdictions is clear: the hospital and the clinician who made the decision to use the system. But we have another responsibility, additional responsibility. The healthcare leaders, we have an additional responsibility because real incidents involve human life. We cannot afford to learn from catastrophic errors. We must learn from experiments like the anthropics before the patients pay the price. With this in mind, let's return as the final part of this presentation to the ethical issues. But now with the awareness that we must not only ask what do we want AI to do, but also what could AI do to accomplish those objectives in ways we never intended. The leader does not abdicate responsibility in the algorithm. It assumes, it explains, humanize it. And there are three questions that the essential leadership must be sure to have. Technical curiosity. Leaders must be curious enough to understand what the tools are doing. Ethical sensitivity. Ethical sensitivity enough to recognize when they overrule them. And the most important, in my opinion, anchor in patient-centered values, because patients are people, and the people are the most important than everything. And to have this on the center of the situation probably will help the clinicians and the people who are taking care of that to be clear which is the priority. Because the history of medicine demonstrates something. Every great technical advance, from the stethoscope to MRI, has forced us to redefine the role of the physician and the manager. And AI is no different. It's just faster, deeper, and more relentless. It forces us to decide if we want to be mere administrators of complex systems or leaders capable of saying no when something is effective but unjust, or not yet when something is fascinating but unsafe. So, the final question I leave with you is not what can the artificial intelligence do for your healthcare system, but rather what kind of leaders do a patient need in a world where AI can do almost everything except assume ethical responsibility for each for its decision? And the leader should have clear vision, strong governance, investing in education for him, her, and the team, and with a very clear ethical framework and again patient-centered focus. And that leadership, ladies and gentlemen, no other, is what this era demand of on us. And more than 4 decades ago, Isaac Asimov, a visionary writer, warned that there was a cult of ignorance taking root in modern societies, a weight of thinking that placed opinion and prejudice at the same level as knowledge and evidence. He spoke of a dangerous illusion, the belief that my ignorance is just as valid as your knowledge. And yet, today, in 2025, we live in the most informed era in the human history. We carry in the palm of our hand instant access to much of the accumulated knowledge of our civilization. We can learn, contrast, verify, and connect with an easy that previous generation could not even dream of. However, the cult that once local has become global. It has evolved, become more sophisticated, and in many ways more dangerous. It no longer rests only on the false equivalence between knowing and not knowing. It's now supercharged by algorithms that reward outrage under understanding, by echo chambers that reinforce our prejudice, and by an overwhelming torrent of information that leads millions of people to choose comfortable belief over uncomfortable truth. We live immersed in a cruel paradox. We have more information than ever, and yes, and yet less shared agreement about what is true. We have more capacity to learn that at any other time, and yet more people who wear their ignorance as a badge of identity. We have more tools to verify facts and data than in any previous generation, and yet more individuals who prefer the comfort of lies to the responsibility of truth. And now, into this fragile landscape, we introduce artificial intelligence, the most powerful tool humanity has ever created. What will AI do with this global cult of ignorance? The uncomfortable answer is that it will not make it disappear. It will use it. It will amplify it. Wherever it finds the ignorance generates more clicks than knowledge, more engagement than nuance, more profit than wisdom. AI does not distinguish by itself between truth and falsehood, between rigor and manipulation. It's simply optimized. If a piece of misinformation triggers more reaction than a carefully argued explanation, the system will tend to amplify this misinformation. If confirmation bias is more effective in keeping our attention than critical thinking, the system will tend to exploit that bias. And here lies the true turning point of our time. The problem is not the machine, it is the leadership that guides it. AI will not define our ethics, our values, or our destiny. We will. The key question is not what artificial intelligence can do, but who we choose to become as leaders in an age where artificial intelligence is abundant, but wisdom is scarce. That's why, in this moment of history, healthcare needs leaders who are something more than efficient managers of technology. It needs guardians of truth, protectors of human dignity, builders of trust in a world flooded by noise, leaders capable of using AI not to manipulate, but to enlighten, not to dehumanize care, but to restore in deepest meaning. Each of us, from our role, whether in a hospital, in a ministry, a clinic, a university, or international organization, has the power to decide how this history will be told. We can allow AI to become the loudspeaker of ignorance, or we can turn it into an ally of knowledge, empathy, and justice. We can be passive spectators of the algorithm or active authors of a more humane future. Leadership in the age of AI is not technical skill, it's more choice. Renew it every day. When the world seems to reward noise over nuance, you can choose depth. When the system rewards immediacy over reflection, you can choose prudence. When it's easier to look away, you can choose to stand up and say, in this institution, in this team, in this community, we will not confuse ignorance with freedom, nor manipulation with progress. The future of healthcare will not be written only in code, data, or algorithms. It will be written in your decision, in your courage, and in your integrity. AI may be the most powerful tool in this century, but you are the conscience that gives direction. So, as we leave this connection, let a single certainty guide us. In the age of artificial intelligence, the most revolutionary leadership will be the one that dares to defend something profoundly simple and profoundly demanding: trust, dignity, and humanity. That responsibility is not on the machines, it's ours. It is begins now with each one of us. Thank you for your attention. Thank you for your commitment to leadership that puts human wisdom in command of our tools, and not our tools in command of our ignorance. The future of healthcare leadership is being written now. Let's write together with wisdom, courage, and unwavering commitment to the people we are proud to serve. Thank you very much.
Thank you, Dr. Jose, for an illuminating session. We had a few questions to ask you if you would oblige.
Yes, of course.
Thank you so much. So in your talk, you said that AI is no longer science fiction and is already widely deployed in hospitals. In which clinical areas do you see a real measurable impact today beyond the theoretical discourse?
Well, one of the clearest signals that AI is moving from pilot to practice is the regulatory pipeline. In medical imaging alone, hundreds of AI tools have now received clearance in the US and Europe. Many focus on lung cancer, stroke, and breast cancer, I have shown before, where early detection has the greatest impact. Beyond accuracy, recent studies show that AI triage and reporting system can reduce emergency departments' triage errors, speed up documentation, and shorten time to critical intervention. For example, in stroke pathways, where AI-driven alert to stroke teams has been associated with meaningful reductions in door-to-treatment times.
Thank you. Thank you. So another thing that we also wanted to ask you is, you insisted that the real disruption is not technological, but about leadership.
Mm-hmm.
What should change today in the way we lead hospitals and health systems to be truly prepared for the AI revolution?
Well, I think it's a good question because from a system perspective, leaders are being judged less by how many tools they buy and more by how well they integrate AI into routine decisions. And international work by the OECD, for example, and others stressed that the real bottleneck is not algorithm, but people capacity, especially the governance structures, skills, and cultures that can turn AI outputs into fair, accountable decisions. This is why leading organizations now define the AI leadership in terms of building multidisciplinary government boards and aligning AI projects with clear outcome targets, such as, for example, the reduced readmissions or imaging block log, and ensuring that performance, bias, and safety metrics are reviewed and I think that rigorously as financial indicators in traditional management.
Right. Yeah. Yeah. Thank you. That makes sense. So one last question that I had was, you also presented a provocative contract, if I may, where the whole system is run by algorithms. So where do you draw the ethical line between decisions that AI can take and the decisions that must remain a human responsibility?
Ethically, the question is not only what AI can decide, but under which regulatory regimes it's allowed to operate. The forthcoming EU AI Act, for example, classifies many health AI systems as high risk, which means they must meet strict requirements on transparency, human oversight, and risk management before they can be used. In parallel, the OECD AI principles and sector-specific guidance emphasize that accountability must remain human. Providers and organizations are responsible for validating tools, monitoring their behavior in context, and documenting when and why clinicians follow or override AI recommendations.
Right.
Thank you, Shojit, for asking the questions, and Dr. Jose. As we conclude this meeting, I would like to thank you for sharing your insights with us. And also on behalf of Adam Global, I would like to thank each member and guest who have joined us this evening. And I'm looking forward to meeting you all next month on the 15th of January, where we will have another monthly meeting. And then a Happy New Year and a Merry Christmas from Adam Global Network.